Without further ado, we will introduce the presentation for today and the webinar, which is about pediatric HIV disclosure and supporting HIV disclosure to children. The impetus for this webinar was started from an article that we distributed through the IATT community of practice called "If I Take My Medicine, I Will Be Strong," an evaluation of a pediatric HIV disclosure intervention in Namibia. And we have several of the authors of that article on the webinar today to present their findings. And more broadly, there have been various systematic reviews of disclosing HIV status in children in resource-limited settings. One in particular by Vreeman et al., which showed that there's a minority of children with HIV in resource-limited settings that actually know their HIV status. And some of these influencing factors are the child's age and perceived ability to understand the meaning of HIV infection, as well as factors related to their caregivers, including education level, openness of HIV status, fear of stigma, and concerns for the child's physical and emotional health. Another study by Arrive et al. Conducted in Côte d'Ivoire showed that there was to assess the effect of HIV status disclosure on retention and care from initiation of ART in children 10 years and older in Côte d'Ivoire showed that disclosure did indeed improve retention and care. So there is some evidence around the importance of disclosure in adherence to treatment and retention and care, and the importance of developing age and culturally appropriate disclosure tools and methods to support children and as well as their caregivers. So with that background and summary, I'd like to introduce our first three speakers as they will be starting off our presentation. So the first speaker is from the Ministry of Health and Social Services in Namibia, Dr. Napewa Amunime, who is a physician and worked for the Ministry of Health and Social Services for more than 20 years. She is currently the Chief Medical Officer for HIV and STIs, and in that role she leads the development and implementation of relevant guidelines and has played an instrumental role in supporting the scale-up and supervision of ART services in Namibia to approximately 10,000 children and 100,000 adults that are currently on treatment in the public sector. Early in the HIV epidemic, she became aware of the special challenges healthcare workers face when managing children with HIV, including HIV disclosure. And she mobilized the ministry and other partners to develop, pilot, and evaluate the Namibian Disclosure Program intervention. We also have with us Dr. Laura Brandt, who is a pediatrician working with children infected with HIV in Namibia since 2007. She's worked directly for the Ministry of Health and Social Services as a Chief Medical Officer in one of Namibia's regions for 14 years before joining the International Training and Education Center for Health, known as IATT, as the Clinical Programs Director in 2007. She is also a Clinical Assistant Professor in the Department of Global Health at the University of Washington. She supports the Ministry of Health national capacity building efforts to train medical professionals in HIV and related conditions, and also contributes to the development of national guidelines. She also has her own clinical practice with pediatric HIV patients, and her discussions with her colleagues made it clear the special challenges in caring for these young patients. And she has worked very closely with the Ministry of Health and Social Services to develop this Namibian child disclosure intervention. And finally, we have Dr. Gabrielle O'Malley, who is the Director of Implementation Science at IATT in the Department of Global Health at the University of Washington, where she is also part of the faculty. She's worked in international health for over 25 years, focusing on the evaluation of capacity building and programmatic research in low and middle income countries. She's conducted assessment and evaluation projects focusing on pediatric HIV disclosure, adolescent-friendly HIV services, retention and care of HIV positive mothers enrolled in option B+, and engagement in care of HIV positive mothers, amongst many other studies. A medical anthropologist by training, Dr. O'Malley specializes in mixed methods program research, and we are delighted and honored to have all of them here with us. So we will first start with this presentation, and then we will move on to a second presentation by Dr. Alice Wellborn, and we'll introduce her following this presentation. So over to you, Dr. Amunime.
Thank you very much and good morning. My name is Ndapewa Hamnime, and I would like to start with a brief overview of what we would like to present to you today. Firstly, I am going to take us through the background which led to the Namibian disclosure process. Then Dr. Brandt will describe the intervention itself, and thereafter Professor O'Malley will describe the recent evaluation that was done. Okay, antiretroviral therapy in Namibia was first introduced in the state public sector in Namibia 2003. The good news is that then many children were started on IATT, and they began to do really very well. But as the children grew, we realized that most of them did not know why they were taking their medications. And also most healthcare workers and caregivers were uncomfortable with the idea of disclosing HIV status to the children. Although they knew that it was important, they were unsure about how to go about it in a safe way. Caregivers also were worried about the potential negative consequences of disclosure. Healthcare workers also noted that without children knowing why they take their medication, it was difficult to counsel them fully and to help them achieve good health outcomes. There were by now a large number of children needing disclosure, and the lack of available specialized professionals such as social workers and psychologists. So we needed to find a way to achieve this with the healthcare workers we have and in already busy clinics that we had then. So we searched the literature for ideas and found that many other countries also reported barriers to disclosure for children, caregivers, and healthcare workers similar to the ones we experience, and which are presented in this graphic model, as you can see, different type of barriers. So these barriers included everything from stigma to healthcare workers, lack of time and training, also to caregiver guilty and so on. Caregivers were also guilty to maybe if they disclose to children, children will start asking questions and so on. Some barriers such as worry about the child's reaction and lack of knowledge about how to disclose were barriers from both healthcare workers and caregivers at the same time. So in our search for these researchers and ideas, we did not find tools that we could use. So then it was a challenge, and what was the solution? So the solution, what we did, we developed a disclosure intervention and integrated it into the routine pediatric HIV care given at the ART clinics. This intervention was piloted, amended, and then ultimately rolled out to all ART sites managing children. We train doctors, nurses, and community counselors as teams so that all healthcare workers have a common understanding and the way forward. So at this point, I would like to hand over to Dr. Brandt to describe the intervention in detail.
Great. Thank you, Dr. Hamanime. So the way that disclosure works in Namibia is that once a child turns 6, the child is eligible to start with partial disclosure, which aims to help the child understand why he or she is taking medication and coming to clinic, with the ultimate target of achieving full HIV disclosure by the age of 10. So any clinician, be that a nurse or a doctor, seeing a patient in this age group starts the process by explaining briefly to the caregiver, without the child being there, about why it's important to start thinking about disclosure, and showing the caregiver the disclosure booklet, which we'll show you just now. Caregivers then, once they've seen the booklet, usually agree that they would like for the child to be exposed to the book, especially since it doesn't mention the word HIV. So then the clinician calls the child back in and opens a disclosure form, which is what you see on this slide, and attaches that to the child's file that's kept in the clinic. So as you can see at the top, there's some background information, and then at each clinic visit, another line on the form is completed. And each time the child is asked why they're taking the medication, and the answer is recorded. In addition, we record the chapters of the book that are read with the child. So this allows multiple healthcare workers working in the same facility who might see children at different visits to know how far the child has actually gone in the disclosure process, so that they can feel comfortable that, for instance, if they've got as far as chapter 2, then they know the next chapter to be reading is number 3, and also they could ask them questions that might relate to chapter 2 and see if they still understand it. So on this slide, we see the disclosure register. The clinician, when they first open a disclosure form for a child, also enters this basic information into a register at the same time, and in that way assigns a register number to the child. So in this way, we can monitor, the clinic can monitor its performance in getting its children started on the process, and actually in achieving full disclosure, because that comes toward the right-hand side of the register. We're anticipating that very soon the essential elements of this form will actually be incorporated into the electronic patient monitoring system in our new patient care booklets for kids. And so in that case, eventually the register will not need to be a paper-based one, and it will hopefully become obsolete at that stage. Okay, and there's another tool that we use. It's really essential for achieving full disclosure. We call it the Assessment of Family and Child Readiness form. And this form includes, as it happens, 17 questions that guide the healthcare worker and the caregivers through identifying concerns and fears related to disclosure and to the child's state of mind and understanding about what the child understands about HIV, why the child thinks he's coming to clinic, what they've already told the child, and what does the child really think. So in the process, the healthcare worker gets an idea of what barriers there are, and in the training we've taught them on ways to go about trying to overcome some of those barriers and worries. Also in this process, the healthcare worker discusses with the caregiver how they would like the child to be disclosed to, fully disclosed to. Would they like to do it at home after fully understanding and being comfortable with it? Would they like it to be done at the clinic, obviously in the presence of the caregiver, or would the caregiver like to disclose in the presence of the healthcare worker? So that's up to the parent or the caregiver to decide. So now let's turn to the booklet itself. It's printed in 6 local languages, and it consists of 5 chapters. And each chapter has a different message, each one giving more and more detail as the child moves through the book, and ending with chapter 5, which facilitates full HIV disclosure. So in this presentation, we've selected a few pages from each chapter just so that you can get the gist of what's going on. So just to describe how the book looks, on the right-hand side is a picture, and on the left-hand side there's some writing. And in black font, which is the writing below, is what you actually read to the child. The blue font includes instructions to the healthcare worker of how the healthcare worker should use this book. So, for example, on this slide, I'm sure you can't read it, but the first bullet for the healthcare worker is to read the page to the child, and while reading the page, point to the soldiers around the body. So at that point, the healthcare worker will read, and he'll say, when you are healthy, there are many strong body soldiers inside of you protecting you from getting sick. And the next bullet for the healthcare worker says that after you've done the reading, ask the child, does the child look healthy? Hopefully the child will say yes, and then ask the child, are you feeling healthy today? Again, hopefully the child says yes, and then you say, what do you think your body soldiers are doing? And hopefully they'll say, well, my body soldiers are protecting me, keeping me healthy. So depending on the age and the understanding of a child, more or less time is spent on each chapter. Up in the top left corner, you see a picture that's in a slide that actually appears both at the end of chapter 1, but also on the back cover of the book. It reinforces the positive concept of a child living a normal life and achieving their goals in life. And in chapter 1, the healthcare worker is actually prompted to ask the child what he or she wants to do when they grow up. And then this answer is recorded in the disclosure form so that we can refer back to it in later visits. The other three pictures on this slide are from chapter 2, which introduces the concept of the bad guy attacking a soldier. And then the effect of the bad guy on the child's health as the numbers of soldiers decrease and eventually disappear. And then, at the end of this chapter, the children learn how to keep the bad guy sleeping under the medicine blanket so they won't fight the soldiers, and the soldiers can be strong. On this slide, the first picture is actually from chapter 3, and it focuses on adherence. It emphasizes taking tablets at the right time, day and night, to keep the bad guy sleeping. The next two pictures, also from chapter 3, emphasize the process for keeping the bad guy asleep. So take your medication, keep the bad guy sleeping, and the soldier strong. And there's also a reminder to the children to pack their medications if they ever go traveling. The final picture on this slide is from chapter 4, and it focuses on what happens if the child forgets to take the medication. And as you can see, the bad guy wakes up. And then you can ask the child, well, what's going to happen now if the bad guy wakes up? The first picture on this slide is still taken from chapter 4, and it introduces the concept of HIV drug resistance. Basically saying that if the bad guy wakes up too much, the medicine blanket doesn't work anymore to keep the bad guy sleeping, and he can go and attack your soldiers. The next two pictures are from chapter 5. All three are actually from chapter 5, but the first two are the ones that facilitate full disclosure. So those are only read to the child when the caregiver and the healthcare worker are prepared and have agreed beforehand to do full disclosure on that day. So once that's been agreed, then the healthcare worker is prompted to ask the child if he or she wants to know the other name for the soldiers. And when we ask the child that, they usually say yes, inevitably. So then they're told that those are CD4 cells. And then the same question is asked for the next picture. Do you want to know the other name of the bad guy? There are also prompts within the book for the healthcare worker about what to say next after disclosing to help them through that process. The final picture shows a lot of pills, and it's really to be used later when the children are taught the names of their specific medications. We don't do that on the same day necessarily, but once they're used to the idea, then it's good for them to learn the names of the medications. So now I would like to hand over to Dr. O'Malley to tell you a bit about the recent evaluation that was done of this Namibian disclosure process.
Yeah, hi, I'm here. I'm just trying to take over as the presenter. So here we go. Okay. So the disclosure program in Namibia had been running nationally for about 2 years when we decided to, at the request of the ministry, do a formal evaluation of how it was working. And our main questions going into the evaluation does the disclosure program help caregivers and healthcare workers engage in the disclosure process with children? Does the disclosure program help children adhere to their medication? And does the disclosure intervention succeed in bringing children to full disclosure? We did the evaluation in 4 study sites that had some of the highest volume of pediatric HIV patients. One of the key ingredients of this disclosure intervention was that it would be easy enough to use so that healthcare workers in very busy clinic settings could incorporate it into their clinical practice.
Hi, it looks like we temporarily lost Dr. O'Malley. We'll just wait for her to quickly rejoin. Does anyone have any questions for Dr. Brandt or Dr. Amunime?
Hello, can you
Hello?
hear me?
Yes, Dr. O'Malley.
Yeah, I was dropped, but
It's
I'm
okay.
back now.
Great, okay.
So we interviewed 64 caregivers at each of the sites, just doing a series enrollment of the ones as they came in for their children to visit the nurse or the doctor. We recruited them for interviews. And then we reviewed over 1,000 patient charts. If you recall the patient disclosure forms that Dr. Brandt shared earlier on in the presentation, those were rich with data about why children thought that they were taking their medicine. So we could really observe through this written documentation the process children were going through. All of the qualitative data was dual coded and managed using Atlas TI. Did you see the slide change?
No,
Okay.
but it's on slide 14.
Yeah, I'm just going now into.
There we go.
There we go.
Uh-huh.
Okay. So one of the things, I'm going to first just start talking about the interviews. One of the things that came up over and over again was how relieved the healthcare workers were to have this tool to help them. It had been very stressful before the disclosure intervention was introduced. And with this disclosure intervention, we heard many healthcare workers express this sentiment. The book simplifies the disclosure process because it is arranged stage-wise. You are building a story and you reach full disclosure. It's not haphazard. And if maybe we were to do it from our own heads, we can jumble things and mix things and actually create problems with the kids that we are disclosing to. It builds the story as you go for the kids to understand. This simple language that the healthcare worker, the caregiver, and the children can all use came up again and again when people were describing what the kids would do when they were talking with their healthcare providers. Even when you ask them why they are taking the medication, that child will tell you that there are some bad guys in my body, and I want my antibodies to be strong and destroy these bad guys. So in this example of what a healthcare worker is reporting on, a child tells them about treating their illness, you can see the metaphor really gives them a sense of empowerment, that they can take some control over these bad guys, and they are going to make their antibodies strong and destroy those bad guys. We found out that the caregivers were also learning from the use of this metaphor in the book. A healthcare worker reported they, that is the caregivers, generally like the book. It also makes the caregiver understand the virus. You would assume that they already know, but once you use that book, you will see the interest of the parent go higher. They will say that I did not understand this myself, so it really works both ways. As Dr. Hamunime said earlier, oftentimes some of the caregivers were reluctant to talk to the children about disclosure about their HIV disease, afraid that the children would get very angry and blame them. And this is a barrier that we find throughout the literature, as I'm sure many of our participants on this webinar are aware. Healthcare workers reported that when you ask those resistant caregiver, does your child know why he or she is taking medication? Do you want us to tell the child? They used to say no, but now when you bring in that book, you tell them at first we are not going to talk about HIV. And everyone says, oh, I like that kind of book. A mother of an 11-year-old boy reported, I like it, referring to the book, because it's nice. There is nothing that can scare the child, where the child might think that if I continue to take this medication, I might die like my uncle. The book encourages the kids that if they continue to take their medicine, they can go to school and become whatever I want to be. And this refers back to the picture that Dr. Brandt described about the child growing up, just like anybody else, and becoming an adult doing whatever it is they want to do in life. Healthcare workers reported behavior change in children. This book is very helpful. Kids easily forget why they are taking medications and decide not to. But if you bring in the book, you will see that it will come back to them that, yes, I have to drink my medication, and like that book, you will see there is a picture of when you grow up. What do you want to do? You know, they get so excited, so they say, I have to go to school, I have to play with my friends, I want to be a teacher. Whatever, that is what they will decide. Okay, I will drink my medication from now onwards. The mother of a 7-year-old boy reported, the child is always talking about bad guys. Sometimes when he almost forgets his medication, he says, no, I am going to take my medication because these bad guys are trying to fight me. So again, what emerges is the sense of empowerment, that the children can manage this HIV disease. They just need to remember to take their medicine, and that will help their antibodies fight the bad guys. We also looked at viral load data as well as adherence measures. So we do have some quantitative support for the qualitative findings I've just described. Those quantitative findings are under review at the ministry right now, so I'm not going to share them in this presentation, but I can verbally tell you that our preliminary analysis shows that there was about 91% of the kids who didn't know why they were taking their medication when they started the disclosure program did show some understanding of why they were taking their medication after they had been enrolled. We believe that children with full disclosure in our sample were more than twice as likely to have viral load copies below, or viral load below 100 copies, and that the pre-post data we have shows that viral load decreased significantly by 0.5 log copies, and adherence scores increased by about 7%. So those are our preliminary figures, and once we review and discuss with the ministry, we'll be releasing those in another publication. So I wanted to just close up this presentation by summing up some of the important steps we believe were incorporated into the rollout of this intervention to make it successful. And one was that the idea for the disclosure book was inspired by a book that was used in Botswana in their pediatric clinic. And one of the first steps that the Namibia program did was to systematically adapt it to its own setting, changing the pictures, changing some of the progression of the events, highlighting and creating different images and steps to the disclosure process. And then it was systematically piloted in 1 and then 2 sites, and that feedback on the disclosure book and the disclosure forms systematically documented, and then the intervention components revised. We found that training healthcare workers on the intervention was very important to its successful implementation. And in the article that Jessica referred to in opening this webinar, we saw that there was a big difference in the healthcare workers who were trained and not trained, and how comfortable they were in using the tools. And then finally, throughout the interventions rollout, we systematically monitored and evaluated all the tools. So we did it in a pilot setting, and then as it was rolled out nationally, we also collected feedback and routinely fed that back to the ministry for ongoing support and tweaking of the program to make it as easy to administer as possible. And that's it. I just want to acknowledge the healthcare workers who participated in the evaluation, and our partners at UCCB, which is part of the University of Namibia, as well as, of course, the Ministry of Health for their leadership and vision in leading this program, and the NIH, which sponsored the evaluation. That's it.
Great.
Questions?
Thank you so much, Dr. O'Malley, Dr. Amunime, Dr. Brandt, for a great presentation. And we have some questions. Just first, in response to the request, there was a request to distribute the book, which the team has kindly shared with us, and we did circulate it a few weeks ago, but we will share it once again as we compile the summary of the webinar and the presentations to distribute within the next few days. So you all can receive a copy of the book. Because countries, it seems, are interested in adapting it to their context. So that's great that this presentation can be a resource for that. Another participant also wanted to know if it would be possible to share the data collection tools, the registers, and the forms that you used. We can also follow up on that online, but I think countries are asking in an effort to kind of, not start from scratch or reinvent the wheel, and learn from what has been done in Namibia, and which was inspired itself from Botswana's experience. So Dr. Brandt or Dr. Amunime, do you have any response to that request? Hello?
Hi.
Yes.
Maybe.
Okay.
Hello?
Go ahead.
Sorry, I was just unmuting. If the request for the data collection tools, yes, that's fine.
Okay.
And I could send them to you,
Okay.
Jessica, so you can distribute them in your normal way.
Okay, great. Wonderful. And we have other questions. So the first is from Carusa of UNAIDS. How do you deal with confidentiality and informed consent when another caregiver who's not the parent brings the child to the facility? And does the book also talk about other family members who may be taking meds, including the parents?
Okay. Yes, thank you for the questions. So if the caregiver is not, the primary caregiver is not there at the clinic, what we do is we talk to the person who did accompany the child out of the hearing of the child, so have the child wait outside, and describe the program to that person and say, we would really very much like to tell the the caregiver who might be the real aunt or somebody, and could they come in the next time that the child comes for a visit. So we wouldn't go ahead without the primary caregiver being there and giving their consent. You asked about other family members. Yes, we've included that in one of our 17 questions is talking about who else in the family is taking ARVs and do they take them together and other issues around it. Not only that, does everyone in the household actually know that the child has HIV? So there are questions. I hope that answers your question.
Laura, do you want to talk a little bit about what happens in those sites where caregivers don't come with the children?
Yeah, there are some sites where many times where the caregivers live so far away that the kids end up coming to clinic on their own. And the way that one clinic has handled it is to have a group, a child group, they call it, different age groups, but they would be talking to them at the beginning of the clinic using the disclosure book, but not ever going as far as to mention HIV. So they have actually used it in that way when the caregiver wasn't there.
Right. The idea being that up until you get to the portion that talks about HIV, the principles of taking medication would be the same for any illness where adherence to medication was important.
Okay, great, thank you. Our next question is from Yai of Ethiopia, and she wanted to know what the age of first disclosure was and the age range of the children that this book can be used with. And if there are several books, my understanding there's one book, but if there's different books for different ages, and if you could talk a little bit about that.
Jump in anytime you want to.
Okay, the age groups actually there is no set age limit or the age which the disclosure should be started. It works on individual basis because some children are quite mature at an early age and some are not. Some even at the age of 10 they still very childish. So we use the same book, but the language and how you and the steps, because as Dr. Brandt said, you start off, then you stop somewhere. If you feel that the child up to this stage the child has understood, and maybe you give more time, after other next follow-ups, then you continue, knowing where you have ended with the child in the disclosure process, so you will continue later. So yeah, the guideline is saying children should be disclosed to as soon as possible, as soon as they can understand things, because rather than to wait when they are big, then it's normally problematic, because they will start to find out for themselves and they can become very angry to the caregivers and to the health workers. So I see there's another question about, there was another question about the ethic.
Let's just ask Jessica if that answers the question. Or it's another question.
Does that answer the question, or maybe?
Yes, I think that the participant is looking for like an age range about, is it, is there kind of a range?
Yeah.
Could this use
that age which we experience is from 6 upwards. But then from 6, what we do is partial disclosure, and by 10 we do full disclosure. At
Okay.
least by 10 we can have a full disclosure.
Okay. Okay, great. I think that helps to frame it, and I think, of course, as you mentioned, that it really depends on the child's maturity level and ability to receive the disclosure. So, of course, there are individual differences within that range even. The next question is regarding, is related, so there's a question before that, but this one is related to the previous one, which is, you mentioned that if some children knew their status before the formal disclosure process was initiated, so do you have any information about those children, how they found out? Was it through their family, and what age and what quality of information they had? For the children who already knew.
Do you want me to take that one, Laura or Dr. Hamanime, or would you like to?
I think if the question is about the assessment, then do go ahead, or else we can add something when you're finished.
Okay. When we conducted the interviews with both the caregivers and the healthcare workers, they were pretty consistent because we didn't talk to the children themselves, but some of the children, we heard both from the caregivers and the healthcare workers that disclosure without the book was sometimes very difficult and resulted in the kid crying because all they heard was, "I have HIV." And sometimes the kids were very confused. They thought about dying, and they were very confused because they had never had sex. So they didn't understand how they could have HIV, never having had sex before.
I'm wondering if we've lost Gabriel.
Yeah, I think we've
Okay.
lost her, Dr. Brandt, so if you could take over while she reconnects.
Yes, I would just add to what she said is that what we found was that even the kids who came in, the older kids who knew their status, it is true that that would be the history of their disclosure, but they really appreciated learning more about HIV because although some of them who learned in a maybe not so safe way didn't really understand the whole concept. So by going through the book again with them, then the penny dropped, then they realized, okay, this is what it is, this is how we can control it by taking the medication and getting HIV to sleep, and that way it really helped them come to terms with the whole thing, even though, you know, they had learned previously in a different way.
Okay, great. A few more questions, and then we'll have to wrap up and move on to the next presentation, but I'm really glad to see that this is generating a lot of discussion. So the next question, and I'm kind of grouping them, so if I've missed your question, I'll come back to it. I'm just grouping them in terms of their relevance to the subject. So the next few questions are around, one is around the experience of mothers sharing their own HIV status with the child and perhaps supporting each other and adhering to medication. So what is have you seen any experiences in whereby using this tool with children also, you know, supports, what is the relationship to maternal HIV disclosure? That's one of the questions. And then another is also just, again, noting that this, how this tool can be adapted to be used by parents and caregivers as well, not just the healthcare workers. It seems a tool that could be used by families. So if you can respond to those two questions.
Okay, thank you for the questions. We have not utilized it for mothers sharing their HIV status with the children. We have noticed that in families where, in many families where they do take the medication together, it's not a big deal, the sharing of the status, because that they know the child knows they're taking the medication at the same time as the mother. And we found that when we've done the disclosure to the child, it hasn't been a big area of concern. But then again, we haven't looked at it at all specifically or analyzed it in any way. These are just anecdotal things that we've noticed. If you find a family where the mother's taking it at a different time and secretive, and being secretive about it with the child, she probably hasn't shared it. Your second question was, I'm sorry, what was the second question?
It was around using the potential for this tool to be adapted to be used by families themselves, not just healthcare providers.
So what we do provide is we provide a home copy. The one copy that I showed you is the nice one that's quite big. It's A4. It's got nice shiny pictures and laminated pages. We do make a cheaper version that's black and white, an A5 size, which if they do want to read the book at home, they can. And then that book excludes the healthcare worker notes. So it's just what you read to the child, and it only goes up to chapter 4. And we do find some kids really like that. We have that available in all the languages. So it's very much something that we want the families to, understand together. We don't have enough books for everyone, but not everybody requested or really would like to have a copy to take home. But whenever they would like it, we do have something available. We also found, just to add something, some people wondered whether the teenagers would be at all interested in looking at these cartoon figures, that they probably are too old for that. Actually, what we found was the opposite. They also love the book. So although the pictures and stuff were geared to younger kids between 6 and 10, actually the older ones like it as well.
Yes, so a couple of questions, couple more questions regarding to process. I think you responded to one of the questions was around children, and did you specifically assess any outcomes for adolescents ages 10 to 14 years? Was there any difference as compared to younger children? And how long does the whole process of full disclosure take? So how many appointments does it require? How many months? Is there anything you can say about the timing and the time it takes?
Maybe Gabrielle, are you still on the line? Would you like to answer about the outcomes in 10 to 14-year-olds?
She's there.
Okay.
Hold on. Dr. O'Malley?
Yes, good.
Sorry. Can
Okay.
you hear me now?
Yes.
Okay, great. Kristen, are you on?
Yeah, I'm here. I can answer.
Yeah, great. Thank you.
We
Kristen did the quantitative analysis for us, so I'm going to go straight to her.
Great. We haven't actually analyzed the results specifically by age, but I think that's a great idea, and we should look and see if there are differences related to the age, looking in adolescents. And for the length of time, it's about 2.5 years that it takes for children to reach full disclosure. And what I still need to do is look and see if the age of the children is associated with how long that process takes. So that's an analysis I have coming up.
Okay. And any information about how many appointments that requires? Is it monthly visits?
I don't have the number of appointments to reach full disclosure. I can look at that, and that's a great thing to look at as well. We have about the average number of months that they go between a visit is about 4 to 5.
Okay.
Yeah.
I think that's helpful as
I could
countries.
just jump in there as well.
Yeah, sure.
Okay, just to say that, of course, it's all very individual, and we have some kids in the clinic who already know their status by the age of 8, and some by 9. As Dr. Hamanime was saying, there's a huge difference in, in the understanding and development of the individual children. And And also, of course, the older a child is, you would really want to fast track the full disclosure. So if you've got someone who's already 12 or 13, and there were some, and they really don't know the status, you really want to fast track that. Whereas if you've got a 6-year-old, there's no harm there's no rush, let's say, to make sure that they know that it's HIV, as long as they know that they've got a reason to take their medication, which is the bad guy.
Thank you, Dr. O'Malley. And I think we're receiving these questions as countries are thinking about operationalizing the tool and how to really promote disclosure to HIV disclosure to children. So thank you. 2 last questions before we wrap up this wonderful presentation and move on to our next one. One is regarding the key indicators you've used for monitoring disclosure activities. So what are your key metrics? And then the last one is regarding the ethics clearance or approval by the IRB for the study to take place. Did it require IRB approval?
We went through the Ministry of Health in Namibia, who did provide it with approval, and we also submitted it to the University of Washington for our own IRB, and they gave it a non-research determination because we were not introducing any kind of experimental. It was already standard practice to implement.
And then perhaps, Kristen, if you're on the line, could you respond to the question regarding the key metrics that you use to monitor disclosure activities?
Sure. So things that we use to monitor them were mostly so we didn't collect any data that wasn't already being collected as part of the program for this evaluation or wasn't collected routinely in patient charts or electronic medical records. So the main things that we're looking at as far as disclosure indicators go was information completed in that disclosure form. So children's responses to why they take their medication over time, the dates listed in the form, such as when they started the program and when they reached full disclosure, if they'd reached full disclosure. Those were some of the main disclosure outcomes. And then for the quantitative results that we're looking at right now, we're using viral load measurements collected every 6 to 9 months or so in children, as well as adherence, which is tracked through an electronic database for the country. And we're using a formula to calculate the % adherence over time.
Thank you so much, Dr. Brandt, Dr. Amunime, Dr. O'Malley, Kristen, for giving us a really clear and informative presentation on how the pediatric HIV disclosure intervention was rolled out in Namibia and being evaluated, and we look forward to your follow-up publication on more results and outcomes as a result of this intervention. So thank you everyone for your great questions. Without further ado, I'd like to introduce our next presentation, which will focus on another very dynamic and well-known tool used to promote disclosure. And this presentation will also focus on adolescents as well, so we're excited about that. Without further ado, I'd like to introduce our presenter, Dr. Alice Wellborn, who's the founding director of Salamander Trust. Alice has worked on international gender and health issues for more than 30 years. She earned her PhD at Cambridge University and has lived and worked in East, Southern, and West Africa for several years. Diagnosed HIV positive in 1992, she wrote a training package on gender, HIV, communication, and relationship skills called Stepping Stones, which is very widely known and used across Africa, Asia, the Pacific, Latin America, and beyond. She has served as a former international chair of the International Community of Women Living with HIV/AIDS and has served as a member and chair of various global councils on HIV. And this new training program that her organization has developed is called Stepping Stones with Children, and this effort was led by her colleague, who's an expert in sexual and reproductive health and human rights, Gil Gordon, and it builds on the success of the original Stepping Stones curriculum and is designed for children aged 5 to 14 years old, orphaned by AIDS, and their caregivers. It was developed in close collaboration with Salamander Trust partner organization called PASADA, which is the largest HIV support organization in Dar es Salaam, Tanzania. So without any further ado, I'll hand it over to Dr. Wellborn, who will give her presentation. Dr. Wellborn?
Thank you very much, Jessica, for that warm welcome, and greetings, everybody. Can you hear me okay?
I think so. You sound
Great.
clear to us, yeah.
Okay, lovely. Let me continue then. So welcome to Stepping Stones with Children, which, as you can see, is a program to strengthen resilience and relationships among orphans and vulnerable children and adolescents aged 5 to 14 and their caregivers. So this is not a disclosure program per se, but disclosure very much forms a part of it, and I'll go on to explain this later. So let me start with the context of gender-based violence globally, and I'll explain why. First of all, we know that WHO tells us that globally 1/3 of women experience intimate partner violence during their lives. Secondly, we know that intimate partner violence increases the chance of acquiring HIV for women by a factor of 1.5. And then a report commissioned by WHO last year, which we conducted, on the sexual and reproductive health and human rights of women living with HIV globally, the women who responded said that 89% of them have experienced intimate partner violence. So you can see that intimate partner violence is essentially a comorbidity for many women living with HIV around the world. So why is this relevant to this talk today? If women experience intimate partner violence, especially if they already have HIV, this will inevitably reduce their capacity to survive. And of course, children will suffer from that. And moreover, children will witness and experience that intimate partner violence in the home also. So if parents die, caregivers who are left looking after the children, often older women, often grandmothers, are angry that their children have died from this dreadful AIDS, grief-stricken, of course, also because they were their children who have died, desperate, overwhelmed by the numbers of children in their care, and they don't know how to cope. Meantime, the children who are left bereft, the orphans, they're bewildered, they are grief-stricken too, they feel that somehow they're to blame for their parents' deaths, so they act up and they misbehave in response. And this is entirely natural, a natural response for a child who is going through something which they don't understand and which is traumatic for them. So, of course, we're not blaming caregivers for feeling desperate and for feeling angry with the children for this behavior, but we do need to understand their challenges and support them in order to support the children in their care. So gender-based violence plays a very large role in all of the background to this program. Now, my next couple of slides are from Susan Casade's presentation in Melbourne, an excellent presentation about AIDS deaths rising amongst adolescents. And of course, all of you on the call know the statistics that Susan presented in Melbourne. And so I'm not going to go into details, but of course you can all have this slide set afterwards. So we're working with 5 to 14-year-olds and their caregivers in order to start young, to support the children and their caregivers as they grow up and become teenagers themselves. So this next slide also gives some more information from Susan that some of you might like to look at later. So moving on quickly, what is Stepping Stones? First of all, Stepping Stones is a program which is based in the community. In 1992, I was first diagnosed with HIV, as Jessica mentioned, when I was expecting a baby. And so that was when we started going with Stepping Stones. It was developed originally in southwest Uganda in a rural setting between 93 and 95. And it includes 4 peer groups working simultaneously of older men, older women, and younger women. And every few sessions, they come together to share and compare what they've learned. So over the past 20 years, the program has, as Jessica explained, been translated and adapted around the world to many different contexts and settings. And then in 2008, Rachel Jukes and her colleagues in the South African Medical Research Council published their findings of a version of Stepping Stones with just the 2 younger peer groups, which showed clearly in their RCT that this reduced intimate partner violence and HSV too. In 2008, we published Stepping Stones Plus, which is specifically focusing on the sexual and reproductive health and human rights of women living with HIV in the context of perinatal transmission. Last year, we published a version of Stepping Stones for Peace and Prosperity, which is for post-conflict settings, which has also been evaluated by Tufts University and has also shown to reduce intimate partner violence. And in 2012, we started working on Stepping Stones with Children, which the rest of this presentation is about. So, Stepping Stones, the original program, here's a map of some of the examples of where the program has been used in the world and adapted and has reduced intimate partner violence in many different cultures and contexts. And particularly, we would like to say that there's been a clear reduction from our pilot programs with Stepping Stones with Children, also a reduction in caregivers beating their children, reported both by the caregivers themselves and by the children in their care after our Stepping Stones with Children workshops in Dar. So we're glad to see that Stepping Stones with Children is following in its parents' footsteps. So moving on specifically to Stepping Stones with Children, a potted history. When we first began the original Stepping Stones program in Uganda back in 1993 to 5, when we returned to the program in 96 to the community, they said what great changes had happened, but the women said, what do we tell our children? This has been great for us, but what do we tell our children? So way back then, they were already wanting to know, how can we make use of what we've learned with children? Subsequently, Professor Rosenboer, who was our chief facilitator and trainer in that original program from Makerere University, developed a program for Stepping Stones in Entebbe. And there she was approached by 10-year-old girls, younger than we had intended, to say, we want to be involved too. So Professor Mboa said, yes, by all means. And at the end of the program, these 10-year-old girls stood up in front of the mayor and the dignitaries in Entebbe and said, we request that we stop being approached by sugar daddies in our community. And that then got turned into a local bylaw in Entebbe. So we know already that the original Stepping Stones works with children as young as 10. However, more recently, we've also appreciated that there seems to have been a gap in material on the whole for children under 14s. We also built on the experience of Dr. Fabienne Ejoaka in her PhD research in Burkina Faso, where she showed that there were huge HIV disclosure issues for children, often who were in their early 20s, but hadn't gone through formal marriage rituals and therefore were still officially known as children, and their parents' fears of telling them about the HIV in their communities. And lastly, we should refer to the PhD research of Dr. Miranda van Rieuwenhoek, who is both a medical doctor and also an anthropologist, who reported in her PhD research widespread sexual activities amongst 10 to 16-year-olds in northern Tanzania. So let's introduce to you our wonderful partner, Pasada, from Dar es Salaam in Tanzania. Pasada has worked in Tanzania since 1989 in Dar es Salaam, which is a city of 7.5 million, a huge, sprawling urban city, and 75% of its inhabitants are without running water or electricity. Pasada has 155,000 clients across the city. It has a long track record of HIV-related health services and is widely respected by all, providing services for people of all religions and all backgrounds. Pasada has already used Stepping Stones successfully, both in schools programs and also with young, older youth, older adolescents in slum programs, and where the slums have been transformed from dangerous places with street crime, drugs and gun violence into amazingly clean, wonderful, peaceful places thanks to Pasada's work. And Pasada was keen to work with us to develop an adaptation of the program to work with younger children and adolescents. So we've been very fortunate in having Pasada as our partner. So what are our planned program outcomes? So we wanted to build on the past Stepping Stones experiences, building communication and strong bridges between the genders and across the generations in relationship skills. We wanted to create a safe and supportive training environment for old and young alike. We wanted to support caregivers and their children to communicate on very sensitive issues, to train caregivers to respond effectively to a variety of different needs and desires of the girls and boys in their care. And we wanted to build small networks of shared mutual support across the communities where they live. And lastly, to reduce the sense of isolation faced by both children and caregivers, and to increase their collective resilience to the chronic challenges which they face. So what are the innovative features of Stepping Stones? Well, reflecting the original program, we work simultaneously with different peer groups. In this case, we bring the girls and boys and the adults together, male and female together, in 3 separate peer groups this time. So 5 to 8s, 9 to 14s, and adults in those 3 separate age-related peer groups. And then now and then the sessions bring them together so that they can share their experiences in plenaries through shared learning. The whole program is holistic and comprehensive, going across psychosocial, physical, sexual and material themes across 29 sessions. Throughout it uses very positive, affirmative, appreciative language, and we'll go into that a little bit more. And it also builds, again, cross-gender and intergenerational communication, which we see as critical. So here we have a slide about the research and development process itself, and we can come back to that later in questions if you'd like, but I'll just move on quickly now to, this is a poster which we presented in Melbourne about our preliminary findings from our 3 pilots in December 2013 and January 2014. Obviously, this is far too small for you to see on the screen, so I'm going to home in on some of the elements, but there's a link to this poster in the notes, which you'll get afterwards if you'd like to look at it. So, homing in specifically on a couple of quotes. We have, first of all, a girl saying, "My father died, but my mother didn't tell me. She just said that he had gone on a journey. Then I went to an uncle's house and my aunt told me that he had died. I am very angry with my mother that she didn't tell me the truth." Now this girl repeated this story twice in 2 successive sessions. So in the case of the girl, we supported her and her whole group to understand that our caregivers love us and want the best for us, and that people used to think that it was best to hide sad news from children in the hope they would just forget about the person, or in the belief that children can't handle bad news. But now we explain to the children that research has shown clearly that it's much better for children to be told the truth. And that's what this workshop is about, to support parents and caregivers to understand, so that adults and children can communicate together much better over such hard things. And this really seemed to help the children to understand where their caregivers were coming from. And they were glad to hear that the research shows that it's better for them to be told such things. And of course, they agreed with these research findings. So in the case of the young adult male caregiver, he said, "I realized when I was shouting no loudly in that role play just now, that this is how I normally treat my young brother when he's being naughty. He must fear and hate me so much when this is how I treat him, even though all I'm trying to do is make him behave. I just realize now that how I behave towards him is going to affect how he behaves." So in the case of the young adult caregiver, this moment was a real revelation for him. He's actually in tears when he was saying it. So we supported him to understand that he'd been trying his best to do the right thing. So his intention was good. And now that he had a different view of the effect of his shouting, that this workshop could now help him to develop a different way of connecting with his brother. So let's look at some lessons learned from these first 3 pilots. First of all, always a good sign, there was 100% voluntary attendance throughout all the sessions. Secondly, children reported during the sessions that they experienced widespread sexual abuse and physical violence. Children expressed strong desires for honesty around HIV disclosure and deaths, demonstrating deep maturity and clear future visions to the facilitators. Caregivers expressed initial terror of disclosure to children, fear of the enormity of their responsibilities and concerns regarding children's ARV adherence, but also, of course, caregivers displayed shared courage and resolve. Several caregivers actually chose to disclose to the children during each pilot workshop, and more caregivers have disclosed to the children in their care since then. Old and young together expressed joy at new learning, relief at sharing, and joint determination to build mutual trust and support between them all. One boy in December 2014, a year on, said, "When did I feel happy? The day my caregiver told me I have HIV." So here's a slide giving an overview of the contents of Stepping Stones with Children, and we've divided roughly into psychosocial dimensions, physical well-being, sexual well-being, and material well-being. And we've shown the exercises which tend to focus more or less on each of these. Of course, something like friendship or going to school, obviously there are aspects of that which relate to all of the different sections, and inevitably there's a huge interconnectedness between all of the exercises, but we just wanted to give you some sense of the kind of exercises which are there, the sessions which are there. And then running through the whole program, and the bottom green line, you can see an emphasis on the virtues which we all have inside us, our strengths, our positivity, mutual respect between everybody, inclusivity and safety woven throughout the program. So we've often been asked what our theoretical framework was for this work, and we've always found that a bit of a hard question to answer. However, with new evidence on interpersonal neurobiology, we can now answer that much more clearly. So I'd like to just explain briefly a triangle of mental health presented by Dr. Daniel Siegel, who is clinical professor of psychiatry at UCLA, which we see connects strongly with our program. So in this triangle, he has 3 equal prime points: the mind process that regulates our information flow in us, our brains, which are actually amazingly really closely connected through our spinal column to the actual workings and energy and efficiency of all of our essential organs of our body, including our heart, our lungs, our liver, and our kidneys. And then thirdly here, relationships, which is how the information and energy which is shared within us as individuals can connect us to one or two, or of course many more people in our relationships. So I don't have time to go through all of these slides in depth, but just looking at each of these corners of the triangle in turn, we can see how we have woven into this program different aspects of each of these three corners of the triangle to emphasize repeatedly different things which are important, obviously, for young people and adults alike to build our strengths and our resilience, particularly in the face of traumatic experiences. So, for instance, in relation to developing our insights about our own thoughts and feelings and empathy for other people's thoughts and feelings. Our gender roles are questioned throughout. We are supporting people to develop self-compassion for themselves through positive language and through a critical consideration of the influence of how we speak about ourselves and others, such as that young adult caregiver was describing. And we also have developed an emotional balance in everybody through regular breathing and meditation exercises. For instance, in relation to our brain and body, we're looking at regulating our bodies, the breathing and meditation exercises again. We do a lot of work on body language and how important it is to use our bodies not only to express our feelings, but also how we can improve how we feel about ourselves by changing the way that we use our bodies, so that that's a two-way street. We can also support participants through role plays and so on to practice pressing the pause button before we blow up. If we're feeling angry, we can understand what's going on beneath our angry feelings. What is it that lies within us to make us feel angry? And we can also, through role play, explore how we can act or react differently in different situations. Moving on then quickly to the third corner of that triangle and looking at communication and empathy and morality, we can look to digging deep within ourselves to make use of the strengths and virtues that we all have in ourselves, to practice these virtues, including kindness, courage, justice, cooperation, self-discipline, responsibility, and a whole raft of other strengths and virtues that we all have within ourselves. And we then are using I statements in terms of assertiveness training, which we've used for many years very successfully with the original Stepping Stones program. And we're also, again, as with the original program, moving from I statements as an individual to we statements as a group of people together in the networks which they're forming as they move from isolation to communication and relationships and resilience. So that was just one example of the many resources we've used. Here's a list of many of the other resources we've used. It's a really rich, eclectic range of resources which Jill and our colleagues have brought together in this training program. Here are a few pictures. Top left, you see the young 5 to 8 year olds showing their individual drawings of their trees of life in their forest of life, which they're building together. Bottom right, you can see them waving together as the storm attacks the forest, and how they can recognize that by moving together, they can all protect each other from the storms of life. Bottom left, you can see that they are rowing through the river of life, finding the balance in the middle of the channel, and avoiding the chaos of one side of one bank and the rocks of the other bank. And then top right, you can see how all of the children and their caregivers are also learning about the different parts of our brains and how they work and how we can make use of them in different contexts, but essentially how we can find emotional balance within ourselves by trying to focus our minds through meditation and breathing and other exercises on those two little triangles which you can see in the middle of that diagram there. And the understanding of even the youngest age group of all of this, understanding how our brains work and how they connect with our bodies, is extraordinary and very powerful to watch. We also have run a participatory film training program with the caregivers and the children, and this we held in December 2014. And you'll just see here some of the themes which were chosen by the participants for their participatory films. The adult caregivers chose to make 2 films, one on disclosure to a child and one on intimate partner violence. The 9 to 14s interviewed each other to see what they thought of the program and also to promote access to schools for girls. And the 5 to 8s, their program, their film was about sex parties in their communities and how they don't want to be exposed to those sex parties anymore. And we've also made a documentary film about the whole program. And these will all be available soon for widespread viewing if you would like. So huge thanks to all of the extraordinary people who've been involved in this program and its development, and a huge array of skills that they all have. We also want to thank our funders, of course, Comic Relief and UNAIDS, and last but by no means least, of course, all of the children and their caregivers in Dar es Salaam who've taught us so much about this program and about their lives. So there are some website addresses for you, and there is one lady and her son who had taken part in the program, and you'll see them on film if you'd like to watch that program.
Okay, great. Thank you so much, Dr. Wellborn, for this really comprehensive presentation, which takes a look at the broader issues surrounding disclosure, particularly among older children or young adolescents. Do we have any questions? We have a comment from Chris who applauds the use of the drawings done by the children and the fact that their faces in that slide were not shown because he feels that confidentiality is very important. And he has another follow-up question regarding one of the last slides in the films that were referred to, and he says, when the children expressed a desire not to have sex parties, what kind of follow-up was done? That there's a fine line between research and advocacy. So do you have any more information around that, Dr. Wellborn?
So I'm hoping that Nelson Chiziza from Posada is on the call, but unfortunately he was having problems getting onto the call earlier. And I don't see him on the call list now, so I'm sorry, because otherwise I would, of course, pass this over to him. I can follow up with him to find out what they've done about the sex parties. The idea of making the films was also to make use of promoting the program amongst other communities around Dar, to invite them to take part in it, but also to highlight to people in those communities what is actually happening. And the whole point about, if you've got a film made by 5 to 8-year-olds talking about these are sex parties are taking place and we don't want them to take place, that in itself is a pretty powerful message. Sorry, that's my computer. Pretty powerful message to elders and leaders in the community to make something happen.
Okay, great. Thank you for that response. And we have a couple more questions. One is regarding the 100% voluntary attendance, which is great and highly commendable. And what were the motivating factors for the participants to have such consistent attendance? And then a second question, given our sense of time running out, is with the critic around peer support groups that take less account of the symbolic and material context, how about the long-term use of the process? So I guess the question, I'm not quite clear about the question, but maybe it's asking about the the sustainability and the long-term use of this training. So the first one is around the motivating factors for the high attendance, and then the second around the sustainability.
Sure. Okay. So the motivating factors for the high attendance, the pilot programs were all conducted residentially, but at the same time, everybody was able to leave if they wanted to. There wasn't any compulsion, and there wasn't any sense of you've got to stay here and so that you get some money at the end. People were given their own travel budget so that they came and went in the middle of the program, so after 1 week. But after that, it was essentially because people were enjoying the program so much, and you could just see the we wished that we had actually done a height and weight monitoring of the children during the course of the 2-week program, and because you could just see the difference in the children over the 2 weeks. And their body language told it all, and seeing the caregivers actually having a football match, the women having a football match during the 2nd week was just fabulous, because they had arrived looking very lost and alone and nervous. And so I think that speaks for itself, that they really actually wanted to be there and were getting so much out of it, despite the emotional challenges of the content. Essentially, they all really felt that they were learning so much from it. In terms of the long-term use of the process, what we're feeling really excited about is that the 14-year-olds, they're already 15 now, and in 3 years' time, they're going to be ready to be trained as facilitators themselves. So, we really hope that we will be able to develop a rolling approach to the whole program, so that essentially, as they grow older, the participants will themselves become the facilitators of all of the age groups, so that there's a real sense of continuity from the program. I was speaking to Nelson this morning, and I'm so sorry that he's not able to join us on the call now. And I was asking him about things like, well, what's happened in terms of treatment uptake and adherence and so on. And Nelson said, well, it's just fantastic the way that people, all of these participants have been so isolated, but now they're really supporting each other. The children are coming to the clinic together, even when it's not their appointment time. There's a real strong network has been built between them all. They're checking up on each other. They're in mobile phone contact. They're seeing each other regularly. So there's a real sense of continuity and community that is built from this. So, we feel positive about the long-term use of the process. Also, a couple of the caregivers I have recently said that they would like to be trained as facilitators. So here also we have, more examples of this turning into a rolling program, which is essentially being community-led.
Okay, and last 2 questions, I think, and they're related to the question around sustainability. And Dr. Welburn, I think you responded in part to one of the questions, which is related to having a graduation process from the younger children to the older children. And you mentioned that some of the older children become facilitators, and then their caregivers become involved. So that's one of the questions. Is there a graduation process or a point where children move from one group to another? And then as some older adolescents who are 14, turning 15, might become facilitators, do you have a curriculum for facilitator training? So that's one question. And then the last question is around have any governments taken this tool to scale and adopted this curriculum and used it at a national scale?
Okay, so I'm hoping also that Jill Gordon is with us. I can see Jill on the call, but I don't know if she can actually speak.
No, but she might be able to type, so I'll encourage her to type in as well.
Okay, so while Jill's typing, and Jill, I hope you can hear and can type. Jill is in the we've just finalized the actual writing of the manual, and as we speak, the formal evaluation process is being started in Dar es Salaam by PASADA. And then Jill's next task is the facilitator. We've already got a facilitator training process which has already taken place by our colleagues in Dar es Salaam for the current facilitators, but we're also developing the next stage of that. So we're developing a training of trainers program, and we really want to be developing a formal accreditation process so that people can move to become formally accredited facilitators and then move on to become formally accredited trainers. And so this is the next stage of the process. So far, no, governments have not taken stepping stones with children to scale. There are experiences in the past of governments having taken the original stepping stones to scale, but this is early days yet for this Stepping Stones with Children program. However, as I explained earlier, we're hoping very much that Stepping Stones with Children will follow in its parents' footsteps.
Okay, thank you so much, Dr. Wellborn, for a really fascinating presentation and for connecting a lot of the dots around supporting children with HIV, supporting disclosure, and as well as supporting their caregivers. So thank you. Just to all of our participants, thank you for staying with us for the length of the webinar. We promise to circulate the presentations, the recording, as well as some of the tools that were requested in a package, and we'll circulate it to you after the webinar. If you have any follow-up questions or requests, please feel free to contact me, and if possible, I'll put you in touch with some of the presenters as needed. Thank you again for your patience and very active participation and great questions, and we look forward to seeing you with us next month.
Thank you, Jessica.
Thank you to all of our presenters. We were very honored to have all of you